Welcome to a special episode of the Donut of Destiny. This episode covers a timely topic. We urge you to listen and take action before September 9th. Find out more at scct.org/double reimbursement.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. Today's episode is the first one back from the 2024 SCCT Annual Scientific Meeting, which was in Washington, D.C., and was an absolute blast. It was great to catch up with friends from around the world, see new science, and learn about exciting advocacy efforts. In fact, one of those advocacy efforts is the topic of today's podcast. So today we're going to be discussing a very compelling proposal that may substantially change cardiac CT reimbursements in the US. To shed light on this topic, we have a returning expert guest, Dr. Ahmad Slim, to help us out. Dr. Slim, welcome back to the podcast, my friend.
Thanks for having me.
Awesome. Obviously, we know each other pretty well, but before we jump into our conversation, I want to remind our listeners of who you are and where you're coming from. So could you talk about where you're currently practicing and discuss the role you've had in leading advocacy efforts through SCCT?
Happy to. So I'm an imaging cardiologist. I work at Pulse Heart Institute in the state of Washington. I'm also the regional chief medical officer there. I'm also the incoming chair of the Health Policy Practice Committee for SCCT, which is really long title for the advocacy committee. And I've been involved with advocacy for the last 15 years, in and out with SCCT as well as ACC Coding Task Force. And I sit on a CPT panel as an advisor on behalf of SCCT. So really long career in coding and billing and advocacy.
Yeah, super thankful, Ahmad, for all of your efforts thus far. And I think some of them we're actually going to shed a little light on later in the conversation. Though before we get into the proposed rules, I do want to give a little background to our listeners who may or may not have listened to our previous episode on the kind of nuts and bolts of billing and coding. So while we covered those nuts and bolts before, can you talk about perhaps the quick history about the current valuation of the cardiac CT codes by CMS?
Yeah, so and I've seen a lot of questions on this topic right after the meeting because there was a bit of confusion among constituents of what is what. So to simplify it as much as I can, anything in a procedural world falls under something called CPT codes. And these CPT codes are divided between professional component, and that's what the provider gets for reading these studies, and a technical component, which covers the whole gamut of the text, the equipments, the supplies, so on and so forth. We do not get paid the same amount of money between the outpatient world and the facility inpatient ambulatory world. These are two separate billing components. One is called OPPS, and that covers hospitals and inpatient facilities and ambulatory facilities. And usually the reimbursement for it is higher than pure outpatient facilities because of the overhead that it comes with. And the second component is what we call the Medicare physician fee schedule. And it's usually a lower payment, but it's done on the outpatient world. And we call these category 1 codes. These are established codes where we get paid off of historical data and surveys that are sent to providers.
Gotcha.
The billing component for the hospital is a little bit more complex than that. It's based on something called Charge Master, which all the billing for the ambulatory setting or the hospital is collected under. And it falls under a revenue code. And whatever you drop in that family gets averaged and gets diluted. So in the past and up to now, the cardiac CT falls under the general CT codes. So pretty much everything CT, to include a quick, high resolution CT scan, is bundled in the same family. And as a result, OPPS always valued cardiac CT at a very low cost despite of the fact that it's cumbersome and it requires a lot of equipment support, acquisition software, 3D rendering, the whole 9 yards, that costs a lot more than what is getting reimbursed for.
So, Amada, perhaps this may be a bit of a rudimentary question, but me as an outpatient imager, when I perform the interpretation for a cardiac CT and then subsequently bill for the professional component, that current professional component is linked to a code that falls under, roughly speaking, a radiology-based coding scheme and is therefore kind of undervalued compared to the amount of work that is put in both on the professional and technical sides to perform a cardiac CT. Is that correct?
Nope. So I know it's a little bit nuanced. So our professional component is based on off of a survey that is sent to the providers on regular basis. So when the first family of cardiac CT codes were generated, there was a survey that was sent to providers that does imaging. And that survey will give you an array of different imaging modalities, and you try to compare your work to it. And off of that survey and the amount of time that's tracked, they determine how much you get paid as a provider on your professional component, both on the outpatient, inpatient.
Hmm,
Cardiology, radiology code does not impact that part. It's really the provider's response to these surveys that determines how much we get paid. The
got it.
biggest problem that we deal with on these surveys is when providers get them, they don't understand the intent of these surveys. They think they are superhuman. So they pick up these surveys and they say, oh no, I am so amazing. I can do this in 5 minutes. When in reality, if you time yourself, on average, it takes you 20 to 25 minutes and sometimes even 40 minutes when you're sitting there doing structural heart disease.
Hmm.
But we do tend to forget all of these and respond as superhumans. When these survey results goes back to the RUC committee in the AMA, they look at it and they say, apparently, you guys don't need a lot of time to do these. And as such, every year, every time that the modality is resurveyed, we lose money because we respond the wrong way to these surveys. What matters, whether it's radiology or cardiology, is for the technical component, our ability to run the test. Our ability to run the test is determined, especially on the OPPS world, on where the code resides. For example, if you look at stress echo, it's roughly reimbursed around $500. If you look at a nuclear test, it's about $1,400 for technical component in the OPPS
Hmm,
because they fall under the cardiology code. So the averaging of these studies does not lower the value.
I see. Okay.
Versus if you grab cardiac CT, despite of the fact that it is as cumbersome to perform as a stress echo, you're getting paid $175 for it. When in reality, when you look at the actual cost, it's at least $350 at least, without accounting for the nurse time and everything else that comes with it. And that's always been the Achilles heel for our ability to increase the value of CTA because CMS has an equation and they stick to that equation when they calculate the value. And as long as CCTA resides in the general CT codes, they can't override that. And as such, the value would always be undervalued for cardiac CT.
Got it. Okay. Thanks for the clarification. And I think that brings us nicely to the main meat of the topic here, which is the current proposed rules by CMS. So, can you help our listeners understand a brief summary of what these proposed rules are for 2025 and why it is so urgent to talk about them right now in this upcoming time period?
And to be honest with you, this is unheard of. It is almost unheard of for CMS to consider doing anything that increase reimbursement for any test, let alone an imaging test. Uh, but to summarize it, the proposal from CMS is that if CCTA moves from the 35X series, which is the general CT series, to the 48X series, which is the cardiology revenue code, they will increase the reimbursement from $175 to $386. A huge
Wow. More than
jump.
double. Jeez.
And this has never happened before. And to give a little bit of a historical perspective to the audience, the reason this is happening is SCCT has been on multiple fronts tackling the issue through advocacy. We've submitted 2 congressional letters to CMS, supported by multiple Congress members, in support of increased reimbursement for CCTA because of health inequity and the fact that patients who truly need the test can't get access to it because of the low reimbursement, not allowing hospitals to buy the right equipment to provide it. We had a senatorial letter of support as well, but signed by multiple senators. And we engaged directly with the leadership of CMS, and they were very receptive and really appreciate all the time they've given us, and they understood where we were coming from. And they worked with us to look at different models to be able to account for this. And CMS themselves, they performed an analysis and a pilot to see if the data that we provided is true. And it was a result of that analysis that led to realization that yes, if systems and hospitals and providers are willing to submit under the cardiology revenue code, and we get comments, because right now CMS releases the proposed rules and they have a comment period that will end on September 7th. That if more than 50% of the comments are positive in support of the migration, CMS will move forward and migrate.
Wow.
That is pertinent because right now, CMS had edits in December 2023 allowing us to utilize the cardiology codes, but we could not do it because all electronic software is locked in on the 35X, and it's hard to pick anything but 35X. So if CMS does the move and goes to cardiology revenue codes, then as a society, we can engage with all these software companies and ensure that the option for 48X is there. So the hospital systems can go ahead and migrate and utilize it so they can get paid at a 386, which still will be 1/3 of the cost of a nuclear stress test and still the number one class 1 indication test, higher than any other cardiovascular test out there. So this is, in my career, this is the first time I have seen this. And this is a chance, it's an all or nothing. If CMS does not get more than 50% positive responses, they will not re-engage this and will go down to 175.
Wow.
So this is all hands on deck. We need every member to send a letter of support, especially if the revenue cycle person from the hospitals co-signs along with them. That will go a long way. They can go to SCCT website and right away they'll get a flash banner that will take them directly to that link. We have talking points that they can engage with the revenue cycle person using the talking points, explaining what I just explained.
Mm-hmm.
They have template letters that they can sign or they can get their leadership to sign. And we have the link to CMS where they can submit these letters and comments.
First of all, Ahmad, I mean, super kudos to all of your work from the advocacy perspective to bring this to CMS in a multitude of different fashions. It's obviously taken years and years of work to even get to this point. So from all of us imagers out there, thank you. We're obviously compelled now to help these efforts get to the finish line and submit these comments in favor of these proposed rules. Now, this is a little self-evident, but perhaps you could help me understand from a couple of perspectives why this will be so beneficial to us. So me as just an outpatient cardiac imager who doesn't own any equipment but reads my scans from my clients, me as a hospital administrator who does own equipment and is in the process of either refurbishing or buying new fleet, and then maybe a hybrid of the two, a practice manager / owner who is an imaging cardiologist or radiologist that is thinking about revamping some of the equipment they have. Could you talk from those three perspectives as to why this is going to be so helpful?
So, yes, because if we can increase the reimbursement for the technical component under the OPPS, usually the physician fee schedule will follow suit, and the assignment for the outpatient world will increase as well. So this will be a win-win regardless of where you do it. The second part is, and I've had this question a lot, is, well, if it goes to cardiology revenue code and we're radiologists, does that mean we won't get the credit for it? Or does that mean our department will not get the credit for it? And the answer is no. The revenue code is reflective of the procedure itself. For example, stress testing is cardiology code, but there's many radiologists that read it and their department gets the credit for it. CT and CTFFR, for now are radiology codes. And when I read them, my department and me, I get the credit for it. The revenue code is more on the billing side, not the internal realignment of resources side. What this would mean is if the value of the test, if the reimbursement for the technical component of the test is increased, then we're actually able to expand the services to the patients that truly need it. Right now, most of the services are done in major hospitals and ambulatory services linked to these hospitals that are willing to absorb the loss that comes of doing cardiac CT because they're able to do other tests.
Hmm.
Versus, the places that truly need the test, the rural areas, the smaller hospitals, they cannot afford the cardiac package technologies, the higher scanners resolution, the
Mhm.
software for analysis, even the imagers. They can't afford to support the imagers to be able, with the volume, to keep the skills and maintain it and be able to do it. So an increase in a reimbursement will ensure that they can have the right equipment right at the door of the patients who do need it, but also will ensure that the skills are maintained for providers to be able to do these tests and not only in centralized location. So even even if I go beyond that, I can simply say, let's say that you're someone in an urban environment, but there is a rural area that needs the test, and now that the reimbursement went up, we're capable of putting this equipment there. Then through teleradiology, you're able to support them, which will add more to your expertise, but also expand the care to the patients right where they need it.
Fantastic. Obviously, all of us that do cardiac CT would be compelled to support this particular proposed rules. And as you had outlined, the SACT, probably a lot through your efforts, have created a very straightforward method by which we can utilize the resources from the society to very quickly and easily get these comments to CMS. As a as an opinion from you, what do you think is the likelihood of success of this proposal?
It's actually very likely. They are truly they're not even looking for um, people to simply say we are ready to commit tomorrow and we're going to convert tomorrow, because they do know there's some legwork that comes with it. They just want a positive letter, a letter that says we want to do this, and if even if there's obstacles in the way, they want to know the obstacles. In the same letter, you can state these are the obstacles that I might face, but I truly want to move forward with this and support this migration because it's the right thing for the patient. So CMS is really looking for the willingness to proceed,
Mm.
understanding that it's something that's going to take time. But there have been great partners in supporting this effort. And if it fails, it just fails because we didn't comment.
Mm.
It really does. So as long as we ensure that we have adequate comments and people submitting comments with willingness to do it, I see this happening and happening soon.
So, Ahmad, this may be a bit simplistic, but from the perspective of the imager, CMS is stating, we'll give you more money to perform these exams. Do you want that?
Yeah, pretty much.
Okay.
Pretty much. But they also know that as an imager, you're not the only one doing this. So that's why it would be very helpful when you have a practice manager or revenue cycle person sign up with you and saying, this is worth the effort. We're going to
Okay.
do this, and it's the right thing to do.
Many practices across the United States interface with more than just CMS as a payer. So, all things going well, let's state that these proposed rules go into effect. What effect might this have on non-CMS payers, if any?
So, both the American Hospital Association and NUBC, which handles the revenue codes as it relates to private payers and hospitals, are in support of this migration, and they're going to submit, hopefully letters of support, based on my understanding,
Hmm.
which will go a long way in the sense of if you migrate to different revenue code under CMS, that means you're migrating under a different revenue code under private payers as well. So the
Interesting.
same methodology, it might not be the same exact methodology that CMS uses, but following the same route would result in an increase in payment on a private payer side because, again, having it in a general CT category is getting diluted by other tests versus having it under the specialized cardiology revenue code. The family that is bundled with is very small, and the analysis is more detailed that allows increase in payment, not decrease.
Awesome. Ahmad, thanks so much. I think we've covered a ton of ground. Obviously, we have a huge action item for our imagers that are out there. Do we have any final comments before we close?
I cannot stress it enough. I know asking folks to do it in the next 4 weeks is a big ask. And sometimes it might not happen right away, but it's urgent. I cannot stress it enough. It is urgent. And this is the first time in history of cardiac imaging a test is going to double its value. And this is one once in a lifetime opportunity, and we're not going to get it again. So please comment, comment, comment.
Awesome. As always, thank you so much for your time and expertise. Really, really appreciate it from me and all of the imagers that are out there. Thanks for not only coming onto the podcast, but putting in all of the effort to get to this point where it seems like we're just moments away from the finish line. And there's really one last set of steps that our audience members and really all of those in the cardiac imaging community can take to help this. So thank you very much, Ahmad.
No, thanks for having me.
Listeners out there, as you heard, we encourage you so much to take action and submit comments to these proposed reimbursement rules. The SCCT has made this a super easy process. Check out the website for more information. That banner leads you right to the ability to create the comment section. Listeners, I know you love what you hear from us on the podcast, but it helps also to rate, review, and subscribe to us. That helps others out there find this content. Once again, this is the Donut of Destiny. Cheers.